Hello, everyone. So I'm Katerina. I'm looking forward to opening up this session on renaming PCOS. And I want to invite Professor Anju Joham, who's a clinical academic and endocrinologist. She works at Monash University and is lead of the PMOS Epidemiology Research Center. And she's going to talk to us about the name change, the why and how.
So thank you very much to ESHRE for this invitation for us to present this journey that's taken, it's a 10+ year process that we're presenting to you, and the three of us that are going to present today are presenting on behalf of the PCOS Name Change Committee. So there'll be three speakers in this session, so myself from Australia, Professor Terhi Piltonen from Finland, and then Rachel Morman from Verity UK, which is the consumer organisation. Okay. Yeah, I'm trying that. I'm pressing the green button. Oh, there we go. So we have a patient video here just to kind of show why we're doing this, why are we actually here. So do you mind playing the video, or if I press green, will that work? So is it not playing? Okay, that's all right. The video might not be playing, but...
When I first discovered that I had PCOS, I was overwhelmed. Polycystic ovary syndrome. The name itself is heavy. It also did not explain any of the symptoms I was having. And to tell you the truth, I didn't even have cysts. That is why this movement is so important to me. We must have a name that tells our real stories.
So this is why we're here. These are my disclosures. So now we look at the why. So why do we need to change the name? So looking at the clinical features of PCOS. So PCOS is very much an endocrine condition. So there's a milieu of endocrine changes, starting with insulin resistance that's present in 75 to 95% of women with PCOS, which is seen on euglycemic hyperinsulinemic clamp studies. And this is even there in lean women with PCOS. There's androgen excess. There's GnRH pulsatility changes, which leads to an LH-FSH imbalance. There's elevated AMH, which leads to follicular arrest, adipokine dysregulation, and IGF signalling issues. And in terms of ovarian morphology, so the name polycystic ovaries implies that there is a pathology with the ovaries. So what is the current pathology? So Professor Piltonen recently published a paper looking at the ovarian features of this condition. So we see here that in PCOS, there is indeed polycystic ovary morphology with increased follicles in women with PCOS and increased ovarian volume, consistent with the diagnosis of PCOM. Interestingly, if we look at the corpus luteum, presence of corpus luteum, 27% of women with PCOS in this study actually had a corpus luteum compared with 37% of non-PCOS. But what about actual cysts, so benign and pathological cysts? So what this study actually showed was that there was no difference in benign cysts or pathological cysts between PCOS and non-PCOS. So there's no increased cysts in PCOS. So we've established there's no increased cysts. It's an endocrine-derived, driven, arrested ovarian follicles, but the broader features of the condition are neglected by this name. And the name and classification indeed has a lot of downstream harm. So is the name important? Absolutely. because what it truly is a multi-system condition affecting a wide range of systems, and it goes much beyond the ovary. So this condition affects 170 million women globally of reproductive age, and if we think of the fact that it actually extends beyond menopause, it actually will be even more. We estimate that greater than 70% of women with PCOS are actually undiagnosed in the community. So there was actually a workshop in 2012 at the NIH that actually voted to change the name. So that's a long time ago in 2012. But then there was a lack of consumer engagement at the time and lack of leadership as to unclear who was going to be leading this change. And it's also a very big body of work. So polycystic is a misnomer, as we've covered. It focuses on a single organ, the ovaries, masking a truly multi-system condition with a lot of downstream harm that impacts policy, funding, research, education, care and our health outcomes. But what it actually is a condition that is an endocrine, metabolic, reproductive, psychological and dermatological condition. So the International Evidence-Based Guideline was published in 2023, looking at the assessment and management of this condition. And the evidence has been sourced from 6,000-page technical report that is freely available if you would like to look at the evidence. And there's also been an evolution of genetic evidence which supports the endocrine and metabolic origins of this condition. So PCOS is truly a chronic complex condition. We've looked at some of the endocrine changes earlier, but it's actually a polygenetic condition with epigenetic features in utero and environmental metabolic features. And the reproductive features, while they were predominant and best recognised, there are indeed significant metabolic, dermatologic and psychological features. PCOS is indeed something with clinical features of the life across the lifespan. So in adolescence, when it first might be recognised, features are usually more around increasing BMI, perhaps psychological burden, and in the reproductive years we see subfertility, increased pregnancy complications and metabolic features starting to become more significant. In postmenopause, the condition doesn't disappear. It is still present, but more of the metabolic features start to predominate. The diagnostic criteria for PMOS was updated in the 2023 guideline. The main change being that in adults, there is now the addition of AMH, which can be done in lieu of polycystic ovary morphology on ultrasound. And the other two criteria, oligoanovulation, clinical and or biochemical hyperandrogenism, they are still the same. So the thing to make clear is that the name of the condition has changed, but the diagnostic criteria is still the same. The condition is still the same, just with a different name. The adolescent criteria are different, so because of the ovarian changes that can happen as part of normal pubertal development, it is recommended that polycystic ovary morphology is not used in adolescents and also not including AMH levels because they don't peak till age in the early 20s. So for adolescents, both the criteria of oligoanovulation and hyperandrogenism need to be met. Some of the major challenges in PCOS are actually with adolescent care, and so with that ovarian pathology not being included, it's not even part of the diagnostic criteria in adolescents, yet we had a name that said polycystic ovary syndrome. The other thing is the predominant metabolic features. So we've previously seen that there's clustering of metabolic features in PCOS with increased diabetes, dyslipidemia, insulin resistance, even hypertension. But recent studies have actually showed that there's actually increased risk of cardiovascular events. So this large study from the UK actually showed an increased risk of cardiovascular endpoints, and this is in young women who are premenopausal. And some of the modifiable risk factors here were weight gain and type 2 diabetes. However, the increased cardiovascular events are not just linked to obesity, because in this study done in the Nordic countries showed that this cardiovascular risk was actually high in women with BMI less than 25. So that is, so we've covered the why we need to change the name, because it's an endocrine condition, there's actually no ovarian cyst, and it's a multi-system condition with broad clinical features. Now we look at the how. So this process, so it started with the NIH workshop in 2012 that recommended a new name. But why did that kind of not go ahead? So there was a lack of kind of global leadership who was going to take the lead. We didn't really have engaged with the consumer societies as much then, and there was a bit of fragmentation around that. And then what was the name going to be? And then how were we going to implement that? So this is not something that's happened very quickly. It's been a very, very long journey. And this initiative that I'm now going to present to you actually addresses all of these 4 barriers. So the first thing we did was actually establish a mandate for change. So we actually conducted a survey of nearly 8,000 participants, including patients and health professionals. And what we determined in this is that, yes, we do need to change the name because the current name is inaccurate. And in terms of achieving this change, how we then went about going through this is that we went through a significant consultation process. So this spanned 6 different continents, and we also looked at the knowledge gaps that were present in 2015. This was there in both patients and clinicians, with a lot of patients and even health professionals stating that abnormal cysts were a part of this condition. What we've seen now with some data in 2023, following a few iterations of the PCOS guidelines, is that there's an improvement in this knowledge, not just from the guidelines, but also from global patient advocacy. And then the name change was actually, there was an initial workshop at the International Androgen Excess and PCOS Society annual meeting in 2023, which endorsed this name change, and there was a strong support for this name change. And we actually then went through another survey which reached 22,000 participants. And essentially the overwhelming support was in change for the change, name to change. And so how do we go about kind of doing this? So we engaged a lot of different people across different continents, several partners. So we had 56 different partners in terms of partner organisations. The lead for this change was Monash University in Australia. Verity, the Consumer Society in the UK, has had an absolutely significant role in reinvigorating this process that had kind of stalled and lost a bit of momentum. And the Androgen Excess and PCOS Society have also been instrumental in this. We covered every possible kind of discipline that could be involved in the condition of PCOS. We covered patient representatives from across the globe, and we had an international steering committee with both patients and health professionals from a multidisciplinary background. And the AE-PCOS Society board acted as an advisory board. These are some of the 56 partners that were linked to this, and you can see that there's a wide range there, including both health professional societies and also consumer societies. So this was a really vigorous global process. So we undertook a modified Delphi process. So what this was a serial set of surveys, and then this was then followed by nominal group technique, which is a structured workshop approach. So initially we built on the prior surveys, then we established a steering group, we engaged with the societies, and then we sent out even more global surveys, and then we undertook this consensus workshop with further surveys and nominal group techniques. And then we came upon the new name, and now we're kind of implementing the new name. So this process has started in September 2024 with governance and funding. Then we undertook the Delphi and the workshops and further surveys until we had the final consensus workshop in February 2026, where we had 97% agreement about our new name. And now we're in transition in implementation strategy, which we have a 3-year implementation plan. There's been an unprecedented scale of global involvement. So this is a condition that affects a large majority of women. There's been greater than 22,000 survey responses, 56 organisations engaged, and there were 19 nominated workshop representatives that led to this name change. And these were globally nominated experts, also on the steering committee, the advisory board, and also from the PCOS guideline groups. And patients have actually collated this process at every stage, looking at principles and practices, looking at governance, engagement, involvement, also looking at cultural appropriateness of the new name, and they've been absolutely key in the dissemination and implementation of this new name. And in terms of new names, so what were some of the naming principles? So we and the consumers wanted something that was scientifically accurate. We wanted something that would help improve patient outcomes and facilitate diagnosis and awareness and help facilitate evidence-based care. We wanted a name that would avoid stigma. And we wanted something that would be clear and easy to communicate, that was culturally appropriate and easy enough to implement in terms of feasibility. So with this naming approach, we wanted an accurate name, but then there was thoughts maybe we have a generic name, something like asthma or diabetes, but actually this was not supported. There was some preference initially for maybe retaining the PCOS acronym. However, this was actually not supported because it was compromising the accuracy of the new name potentially in favour of retaining the acronym. So 82% supported in these surveys that what we should proceed with is an accurate symptom-based name. So the preferred combination of the new name is that we looked at the different domains, so we wanted something that represented the endocrine, so we had different terms, and the leading term that came out through the consensus workshops was polyendocrine, and the next alternative was endocrine. With metabolic, the other alternative was cardiometabolic. And then we had ovarian, and an alternative there was reproductive, and that is a term that we definitely didn't consider because the name reproductive does have broader applicability, broader than the ovary. For example, endometrial changes, reproductive changes, pregnancy complications. The reason that we did not proceed with that is because of some of the cultural considerations and the stigma with labelling someone with a reproductive condition, and that is definitely an issue more in some parts of the world than in others. So that was based on consumer feedback that we did not use the term reproductive. And so this new name, we looked at how all the terms would combine into a name altogether. What would the acronym be? And is there something similar out there, for something else? And what are the language and cultural implications of the new name? Some of the issues raised were around the stigma around the term reproductive, the fact that there's a potential male phenotype and the new name potentially doesn't cover that, the different subtypes of PCOS, and also all the impact of actually changing the name. And we actually did engage some marketing advice into this, and so we actually used that advice in determining the new name as well. So from all of this very long process and surveys and consensus workshops, we have a new name. So this was published in The Lancet in May 2026, as most of you are probably aware, and the new name is polyendocrine metabolic ovarian syndrome. And the steps that I've outlined kind of show how we arrived at that process. Next, I'll hand over to Professor Piltonen to talk about the global implementation of this name change.
It's a pleasure for me to introduce the second speaker. The Professor Terhi Piltonen is a full professor in the Department of Obstetrics and Gynecology at Oulu University Hospital in Finland. She also practices at the Reproductive Endocrinology and IVF unit. Her research team focused on the lifelong health of women with PCOS using register-based data, mouse model, and clinical samples to investigate metabolic outcomes and endometrial function. She has been actively involved in international guideline development groups, and finally, she is the president-elect of the Androgen Excess and PCOS Society. So, thank you.
Thank you for the lovely introductions, quite long there. So I'm the current president of the International PMOS Society, and otherwise I do not have any conflict of interest here. So I think we need to next look into the implementation strategy. So now Anju has told you about the rigorous and inclusive medical naming process that now beholds the new name polyendocrine metabolic ovarian syndrome. So there were many of the organizations, including ESHRE, that were involved in this process, and there were a very high number of survey responses to capture the idea that we should changed the name, and then there were also consideration what the new name should be. And after that, we had the workshop of 90 representatives. So with the implementation science, there are different strategies, and we implied them. So this is according to the current literature, how we should do this process. And then also there is an embedded evaluation strategy inside. There is accountability and monitoring global uptake plan that I'm going to tell you about. So what does this mean for patients altogether, naming the change? And with the video, I think you were already able to see that people have been waiting for this change for quite some time. So there will be better understanding and less stigma for sure. With the accurate name, the understanding will broaden this condition, as we all know as clinicians and health professionals that this is broader than just the ovary. We have removed the misleading cyst, as you showed with the population-based data, that that everybody who are doing the ultrasounds, we are able to see that these are not cysts, these are small little follicles in the ovary. But many times we are referring them as a cyst, and that is quite a misnomer. And then reducing the reproductive stigma, I think particularly significant in some of the cultural contexts, because we did not choose the word reproduction. I know that many of you were thinking about it, but this was not the end result of the surveys or the consensus in the end. We have now recognized the metabolic and psychological and cardiometabolic features of these patients and clinicians, so that we are able to involve more multidisciplinary clinics to help these women. And then, of course, in the end, we wanted to have a name that really is able to adopt with the previous name, so that not everything is new. So there is something that we can still keep with the new name, and that was the marketing experts that really recommended doing this. So only one letter has changed from the previous acronym. What about the clinicians and researchers? How about us? What do we gain here, or how does it affect our clinical practices? So definitely it will now frame this condition as a multidisciplinary framing. So there will be endocrine and metabolic workup. I think we're going to focus more on that instead of just looking into reproductive hormones and looking for the ovulation. And then reduce diagnostic delay, as these symptoms will be more clearer by the name itself. There will be a better alignment with the international guideline diagnostic criteria assessments, what we have already been recommended earlier. And then, of course, improve patient education and communication about the full length or the breadth of this condition. And of course, it does support the holistic patient-centered care across clinical domains. And for the researchers and scientists, I think some of them have been worried about, what's going to happen, but I think good things are going to happen. Hopefully, and more likely, we are going to have coherent research classification, funding terminology, that we are able to apply funding for different grants under different topics. And then for the ICD coding changes, this will be towards health systems and kind of showing the burden, the health burden of this condition, and also translating into the data queries. And then for the polygenic research, the coherent framework across neuroendocrine, metabolic, and reproductive pathways, I think this is a very important aspect. And then everything is not going to be changed overnight. There is a 3-year transition period, so we do not need to be worried that everything has to be changed just now. So we do have time. And then, of course, the ongoing evolution of science, that's also has been taken into consideration, that we have now known. It had, earlier in the days with Stein and Leventhal, we started from the ovary, but now, since then, we have become, and the travel has been long and hard, and we've done so many studies and research to really show that this is not just about the ovary. So I think it's time to say that also the name is reflecting this evolution. The implementation, let's see, so the architecture is in place. So now when we have the new name transitioning from PCOS to PMOS, these are the different levels of the system that we will be changing. So the policy, so this means the classification of this condition, the research, there is evidence, and we're going to accumulate more evidence for this condition that is affecting different organs. Education implementation, so we're going to see many of the materials will be changing, and probably they will be more coherent and more accurate than before. And then also, of course, with the education, we are also able to give the women themselves the ownership of this condition finally. And then, of course, in the end, what really, really matters is the care and the outcomes for these patients. So I think we have to also think about this, especially for the patient perspective, not, what it's going to do to me and do I feel good about the change, but the fact that do my patients feel good about this change? I think that's one of the key questions here, or also the answers. So this will be the 8 steps implementation strategy. So first we will have the publication dissemination. There has already been 25 publications. It says 24, but there have been actually now 25 publications that have been endorsing the name change and also informing about it. They are in the high top journals, as you can see. There are resources and global communication implementation strategies. There is multilingual patient resources and 56 society toolkits that have been distributed. There is media and social media outreach. Can you imagine that? There is 1 billion audience research already by now. So this is a huge wave that has now gone through the whole social media and media. 75 million social media hits, and you can see that some of the very top journals have also noticed the name change. And their health information systems, I think we're going to have some changes in our electronic health records and the naming and the nomenclature in those systems. There will be reclassifications that are underway. As for research, of course, notifying the funders that this is the new name, that they should be aware about it, and the mesh terms, of course, and then the research databases that will be changing. There will be top 100 journals. The editors have been contacted about the name change, so they are aware about it. The international classification of WHO engagement with the ICD-10 coding, this is underway. The process have already started. And then there will be a reclassification for this condition, but this will also be happening stepwise. The education efforts is that the global conferences, letters, there have been several of them that have been distributed. The universities have been contacted. There is a curriculum content that will be changed, and I hope that you will now help with all these efforts. And then textbooks, they need to be changed, their vocabulary, and some of these have already started. And then finally, the international guideline that was established in 2018, the next one will be now in 2028, and we will be now using the new name with this new guideline update. And underlying that, there is also the NICE guideline that is endorsing the new name already. So these are the publication plans. As you can see, there are several very high impact journals that have accepted some of these letters about what's going to happen and how do we feel about the name change. There are 25 accepted invited papers already, several of them under women's health, but also more generic journals. And then as for the media and social media responses, there have been all these, the human reproduction has been submitted. The mainstream media, 1 billion people have already endorsed this, so this is already happening. Social media with the 75 million hits, and 80% of them were thinking that this is a very positive change. And for the 20% that were negative in the social media, they actually what was more about it was the fact that the condition has been neglected. So the content of those negative comments were more about the fact that this is very neglected condition, not about the name change itself. So that has to be also captured. So what about the transition? So now when we have these 56 patient and health professional societies, there will be a global rapid consistent messaging around the world. All the societies have actually received a toolkit that has different informatic leaflets like this, and they have been translated in several different languages. And there is also the application Ask PMOS that is now in 195 countries, and I endorse you and encourage you to upload this and share it with your patients, as it does have so many different language options. And then all these are available in different languages, and they are freely available through the Monash web pages, and also in all the societies that we have that we have sent it to. So finally, I would like to say that now it's evident that PCOS is now PMOS. This is a very, very common condition, and is too important to be misnamed for so long. And today we have the most comprehensive, rigorous and inclusive medical renaming process that has been undertaken. So I think we should appreciate also the process. And now we have been also asked to be, all this process is actually being applied to other name change processes as well. And there is the Lancet commissioned implementation paper that we have published. And if we look at the whole implementation strategy, and here are the 8 different points, all of them have been started or initiated, and many of them are in a full speed. And I think, having, maybe 20% of this lecture hall full with this audience, I think that also tells something about that. I think people already know that the name change has also already happened, so they have probably attended another lecture in another room, because I think they've already accepted that this is the change. But I would like to then ask, because I think the patient voice is so important. I think Rachel, that's the most important speaker on this session. So Rachel, please come up.
Thank you very much, Terhi. And I'm just going to introduce Rachel Morman, who is the chair of Verity PMOS UK, which is the UK's leading patient charity for PMOS, and which changed its name actually from PCOS UK in May this year. So Rachel spent 2 decades advocating to improve awareness, education, research, and standards of care for those living with PMOS. And she's played a central role in major and national and international initiatives to improve understanding of the condition. She's advocated in Parliament, has been involved in clinical education programs, international and national guidelines, and the global initiative to change the name. And alongside her charity work, she's an award-winning social media and influencer marketing leader with over 20 years' experience in digital strategy. So we look forward to hearing all about the patient side of things.
Thank you. It's an honour to be here and to represent the patient voice in this session. Thank you for the lovely introduction. Okay. Well, the clicker is very tough, isn't it? These are my disclosures. So as mentioned, I'm a trustee of Verity. I'm a committee member on the NICE guidelines. I'm also on the international PMOS guidelines, and was on the steering committee for the name change. So the name change from PCOS to PMOS is a significant moment for patients around the world, and personally for me. I have been, as mentioned, campaigning and advocating for this change for well over a decade. But I want to be clear that this is not about me or any one person or any one country or any one group. This is very much a consensus process, and I'm here to represent the voices of thousands of women with PMOS who contributed to this process, more than 14,000 of them overall, from every corner of the world, who represent the voices of over 170 million, 70% of which are probably not diagnosed yet. And as you can see, and you've already heard today, patients and patient groups from around the world were part of this process from the very start. And before I speak to kind of the wider patient journey on this process, I just want to address something very clearly up front. because I know it will be on the minds of many people and has been, and certainly has been posed to me since, that were patients really involved from the start throughout every part of this process, or was it more of a tokenistic patient involvement project? And I can assure you from many sleepless nights, many document reviews, many meetings, we were very much involved from the very outset. Patients were integral throughout the process. We co-designed the surveys, we co-chaired workshops alongside healthcare professionals, we shaped the governance, we brought real-world multicultural perspectives that no clinical team could have provided alone. Shared decision-making at its finest, and that distinction matters enormously to me and should matter, and I'm sure matters to all of you in the room and beyond. The history of women's health is littered with decisions made about women's health without women involved, and this was very much different, and it should set the bar for future condition name changes to come. As a patient advocate, I can't scroll. I see every day stories from women that have been confused and misled about their condition, thinking that their rush to the hospital with a burst cyst was because of their PCOS, having ovaries removed because of their PCOS, and really not thinking much beyond that context. And these are not uneducated women. These are women that have been trying their best and have not been, haven't had the justice of a name that accurately corrected. Oh, sorry. The mouse does it too. Hang on. Sorry. Okay. What? Too far. Okay. Apologies for that. We're waiting. There we go. So 97% consensus. In medicine, in policy, in marketing, in my field, this is as close as it gets to 100% consensus. This was not decided by a committee in any one country, and it was not decided by academics alone, and it was not decided without patients. 2 global surveys, international workshops involving patients and professionals from every world region. This is not about one single country or one of the loudest voices in the room. It's really about the 86% of patients, the 76% of healthcare professionals, and 97% of those involved in the consensus workshops that agreed that this name was long overdue. And this is what a fair and democratic, globally informed decision looks like, and that matters, because the people most affected by this name have historically had the least say in how their condition is defined and treated. And I'm sure not everyone will be happy, and that is the nature of change at the scale. But I'm just going to quote my grandmother here, who said that you can please some of the people all of the time, and all of the people some of the time, but not all of the people all of the time. And I think 97% is a really good measure of success here. The name change didn't happen because of patients alone or because of clinicians and researchers alone. It has happened because over decades, quite literally, individuals from these 3 groups who refused to give up, who cared deeply, wanted better. But I want to say something specifically about the patient community, because it is easy for it to get lost in conversations and settings like this. The overwhelming majority of PCOS advocacy around the world has been done by volunteers like myself, who have full-time jobs and families and their own health and condition to manage. We do this work around all of those other big things in our lives because we have been dismissed by our own doctors. We have lit landmarks, we have lobbied governments, we have built communities, we have pushed for classification and recognition when the evidence wasn't yet being heard. And that work, that vital work of patient advocacy, although it didn't create the evidence, it has created an environment in which the evidence that you all create could no longer be ignored. And without that foundation, we wouldn't be here today with a new name. I'm going to put my marketing hat on for a moment and to talk a little bit about the social media impact of the name change. So we can see here some immediate reactions to the name being announced. Things like, this makes a lot of sense. Younger me would definitely have understood this more growing up. Thank you, this will be a game changer, especially for future generations. And I'm a mum of 3, I've got 2 girls. Likelihood is that at least one of them might have the condition, and this really means a lot. You can see in the boxes here around 72 million mentions of PMOS within the first 2 weeks of the name change, and that is almost equal to the 73 million mentions of PCOS. And what that means from a kind of a conversation level is that people are talking about both simultaneously. The name landed and was being used and is being adopted without delay and on par with PCOS. So the worry around risking all of the advocacy and all of the impact that the previous name has kind of gathered, I think we can now put that to bed. You heard also about the sentiment, the positive sentiment and the neutral sentiment around the name change, but I just wanted to show this cluster of conversation. So this is from a social listening tool, and we can see the grey bubbles represent kind of announcement conversations. So the size is around the volume and the frequency of the word being used. So we can see cyst and renaming and women and the Lancet and metabolic across all different languages are really coming through prominently here. And the positive bubbles are about time, change is great, we can't wait for this, support. And then negative bubbles, as Professor Piltonen mentioned, are not about certainly there were some people not happy about the name change, but overwhelmingly that conversation, which I analysed as well, was around, oh, finally, PCOS has been neglected for too long. It's about time someone listened. So that's where the tools kind of pick up negative conversation. I want to speak quickly around implementation and what we're doing here in the UK. So from this meeting, I'm heading into Westminster to meet with MPs, to meet with NHS England, to meet with the Women's Health Minister and GMC and others, where we're going to be talking about implementation of the name change in the UK, coding systems and what work needs to be done. I'm really happy to announce as well that NICE Guidelines adopted the new name immediately for their draft consultation guidelines, which are out now, which have actually been built off the international guidelines. And the NHS now have also formally updated all of their website with the new name. You've heard about the implementation plan. It's a 3-year journey. I was in Italy back in, I think it was 2015, so about 11 years ago, talking about the name change. This has been a very long journey for many people, but it has always been a journey of collaboration between patients and advocates, clinicians and researchers, and that doesn't stop today, and we bring you all along the journey with us now as we head towards implementation. And I just want to quickly end, before I do acknowledgements, with what impact this name change is already having on the ground with patients. If I can get the clicker to move. So this is a story from someone in our community, Victoria, who just filmed this last night for me to share with you today, who in her 40s has now been diagnosed with PMOS because of the name change. This is a direct result. So I'll let you hear from her directly.
My journey with what we now call PMOS spans over 25 years, and it took me through gynecology, mental health and gastroenterology. Since puberty, I struggled with my weight, despite being fairly active and eating reasonably well. Over the years, this grew into painful and heavy periods, IBS, severe anxiety, and eventually a diagnosis of type 2 diabetes because the root cause wasn't being treated. The real turning point came when I was prescribed a medication that finally targeted my insulin resistance. In just 12 months on this medication, my GP believes that I've now reversed insulin resistance. My blood sugars and my blood pressure have normalised. My mental health is the best it's ever been. I've lost 48 kilograms and my periods have returned, and they're completely healthy and painless after a 7-year absence. When the name change to PMOS was announced, it brought an overwhelming sense of validation. For decades, the medical system treated my symptoms as if they were completely separate issues. And whilst I genuinely appreciate the care I received, I didn't always feel I was being listened to. It often felt like the doctors were focused in on their speciality only and believed that they knew my body better than I did. Eventually, I think I just gave up advocating for myself. This name change has allowed my GP to look back at my medical history and connect all the dots. It's finally proven what I always knew. It was never separate illnesses, but one single metabolic root cause. Now that we understand the condition, we can continue to treat it accordingly.
And with that, I'd like to end the session by thanking everybody involved in this process, the 22,000 plus people that filled in the surveys, participated in workshops, the PCOS name change steering committee, all of the authors on the papers, and particularly to Professor Helena Teede from Monash University, who unfortunately couldn't be here today, but very much has spearheaded this change. Thank you very much.
Thank you.
Thank you.
I think if I can invite all the speakers maybe to come up to the podium, then any questions can be addressed. I'll probably start. I think this is so fantastic, particularly for us as well as clinicians. You know, it's obviously so super important for patients, but even as clinicians wanting to advocate for patients, we're often not listened to. And I just wonder what you think from a kind of implementation challenge point of view when we consider funding. I used to have a clinic, a sort of multidisciplinary clinic, which is clearly what we need. And it involved endocrinology, gynecology, and we had that support, which was defunded about 10 years ago now. So what do you think the challenges are going to be in convincing now all of our governments and funding bodies that this needs to be reprioritized and that we need to work in a joined up way?
So if I can answer this part, I think I'm hoping that we would be joined by other disciplinaries more often. I'm hoping that we would get more hands and brains on these women and to be interested. And I think that will be very powerful when we get also other disciplines other than infertility doctors as well to be interested in this condition. And I think that will bring the resources and the visibility.
No, that's...
Oh, sorry.
No, go on.
Just from the perspective of the work that we're doing, certainly within the UK setting, having nice guidelines. I mean, it's 2026. We haven't had proper pathways for PMOS, so it's great that we're getting them, but it's shocking we've had to wait for this long, and many people in the room have helped advocate and bring that about. I think we're having more serious conversations about the condition already now in the last couple of months, because it's finally the recognition that this is not an ovary condition, and it is a whole body complex lifelong condition. So we're certainly having more conversations with policymakers and funders that we wouldn't have been able to really have that conversation with before. So we're hopeful for what's to come.
That's lovely. Thank you. Yes, go ahead.
Yes, hi, Rick LeGros, Penn State, Hershey, Pennsylvania. So I would argue that science is not a democracy. Science is about absolute truth. If I can quote perhaps the world's most famous scientist, Albert Einstein, if you can't explain something simply, you don't understand it. I don't understand PCOS, and I see this name as just obfuscating it more. One of the things I question, hearing it's not an ovarian disorder, I don't know any of the current diagnostic criteria that don't involve the ovary. So I think you've unleashed something. You're going to have to revise the diagnostic criteria to include polyendocrine, which I assume is a gland other than the ovary, and what is the metabolic criteria for identifying this? You know, one issue I have when I hear about insulin resistance, there is no clinical cutoff for insulin resistance. In fact, the American Diabetes Association, American Heart Association created the metabolic syndrome to avoid over-testing of insulin and glucose levels to reflect what the physical phenotype of insulin resistance is. So, you know, those are my main concerns.
Yeah, I think, Rick, I hear your concerns, I think, we've been working on, for example, weight for quite some time, your group and my group, and still weight hasn't been one of the diagnostic criteria even before. So I think I'm hoping to see that with the new name, I agree that insulin resistance and measuring it, we don't have any proper way to do it, but we can certainly treat it. So I think, by having this name or these words in the syndrome, it will, at least, how does it, sound from the patients? It does look like that they've been seen more as a whole. So this is but there will be, of course, it's not perfect, but I think it's the best what we can have now, and I think it looks like that it's better than before, and it's not my opinion. It's from the surveys and the social media outcomes, and also I don't know how are your patients responding into the new name change? Do you have have you talked with your patients?
Yeah, so the largest U.S. patient support group, PCOS Challenge, that Sasha Ati is the head of, is totally against the name and feels that she was a part of this team, but feels she was kind of railroaded into it. And just since I have the microphone, one more thing, we can see what democracy does to science, what's happening in the U.S. with vaccination right now. So I am wary about relying too much on experts to make decisions about the name or even the diagnostic criteria without scientific evidence behind it.
Do you mind?
Yeah.
Yeah, as I mentioned in my talk, Sasha was involved. I know Sasha. But it's not just about one patient group in one country, but really about all of the globe and how this condition impacts and affects care for women around the world, not just in one country, which I'm representing the UK, but certainly we had patient groups from around the world that were all supportive of this name change. Thank you.
Thank you very much. Adam Balin from the UK. The name has changed, and as healthcare professionals we have to embrace it and ensure that all those working look after our patients in the best possible way. And I've worked very closely with Verity and Rachel. You spoke very eloquently on this. There is always going to be some disagreement, some concerns. The point I wanted to make is that when in Rotterdam we defined the PCOS as it was then, we defined the polycystic ovary as having a certain number of these immature follicles. A cyst doesn't need to be pathological. A cyst is just a small fluid-filled structure wherever it might be in the body. And when we do an ultrasound scan, we will still see the polycystic ovarian morphology, which is still at the moment part of the diagnostic criteria, just as AMH is, although as far as I know we still don't have a consensus of what an elevated AMH is. So my plea is to ensure that we get the messages across appropriately about ovulation induction, stimulating the ovaries. These ovaries will respond sensitively. Even if somebody doesn't have the syndrome, we know what the consequences going through IVF might be to have this ovarian morphology. And I've communicated with Helena and the group, when you change the name, we've still got the polycystic ovary. Is that name going to change, and how is it going to change in a way that everybody can understand? Because I think that's really important.
Thanks, Adam, for your comments. So definitely, the follicles look like multiple cysts, but the name polycystic ovary morphology also has some inaccuracies. So the next step following the name change is to actually look at the nomenclature around that. So that process has started, but that process only could happen after we change the name of PCOS. So we're kind of engaging lots of groups that are related to that, so radiology, ultrasound experts, to look at that process. So that's the next step. And in terms of AMH, the new criteria in 2023 does incorporate AMH. And it kind of says that we use lab-specific, lab-based cutoffs based on the specific assay and age-specific ranges, but we don't actually have a clear cutoff at this stage. But that's based on the limitations that we have in the current evidence. So that's something we're actually hoping to identify. So the guidelines, one of the key things it does is identify the gaps. So and so we're actually hoping to, do the studies that actually fill that knowledge gap, and then hopefully provide a cutoff for AMH in the next guideline.
Can we take the question from the other microphone first, if that's okay?
Thank you very much. Kirsten Brand from Germany. First of all, I would like to respectfully disagree, because I've been at the ADA meeting only 3 weeks ago, and the ADA does acknowledge insulin resistance. And if you look carefully into the ADA 2026 diabetes treatment guidelines, there's a whole chapter on diabetes prevention or pre-diabetes that actually acknowledges insulin resistance very well. Having that said, I would like to also continue, and now I have to disclose myself, as I represent a company also that does hold a product with a PCOS indication here in UK. And this actually brings up my plea. We can only change the name to the new name in our labels as soon as the respective systems have changed. So as soon as the METRA, the ICD, also the MESH have updated, then we will be able to really get into updating our label as well. And this is my plea, because as a woman, and we share something, so as a woman myself, I encourage this change very much, because it embraces the disease so much more and is so much closer to the situation that women face.
Thank you. I think, that's well said. The process of changing the mesh and also the ICD coding is underway, so it's already started. Just thinking about, the insulin resistance and the name, I think this will be probably captured now better with the whole metabolic sequela of this condition. So I think, I think it's important to change also the codings. I'm also giving you a kind of a feedback or a message or a plea that the pharmaceutical companies would also run the studies, including women with PMOS, and putting more money in, because we really need the pharma as well here to be able to carry out some of the larger studies, and also then applying for the, how do you say, the compensation or the for the particular medication that the indication would be particularly in PMOS, because some of these reimbursement systems are quite key to be able to take care of these women and for them to get the reimbursement for these medications. Yeah.
I think we have time for just one more question, so if you go ahead.
Hi. Niels Lombok from Amsterdam. I want just to share with this room that I'm one of the frustrating scientists in the field with this name change. I want to be honest in that. And there are a number of reasons that I don't want to discuss at this particular moment. But what I wanted to point out is I've been in the field for 40 years. First of all, I published over 40 papers on PCOS, and I was not involved in the process. I don't know why, but that happened. But over the 40 years that I was in the field, the prevalence of PCOS increased from 2% to 10% today. And one of the reasons is why, and that is because we added more and more diseases or phenomena that came with PCOS. And I think that to some extent contributed to the negativity around PCOS. And we should realize that we're talking about nowadays of something that occurs 10% in the population, female population. It has a heredity of over 70%, almost 80%. So there must be some hidden in the PCOS women, positive phenomena that made them to reach this era that we're in today, even despite the fact that it is associated with infertility. So, and that is what I'm missing in all the discussions, and also in the paper of the Lancet. There must be positive things in PCOS, and we could also point out that that might be the case, and look into that as well. I just want to hear what you think of that.
Yeah. Thanks, Niels. I think you're absolutely right. I think the phenotype has been very beneficial in probably back in the history. I think it's just the environment is a little bit off for the women for this genetic background. So I think, and I always tell to my patients about their lush ovaries, that they're beautiful. There is, I'm always saying that it's more about our problem, how to get the ovulation. But, in the end, they have quite, with the modern ART, there is a very good chance of them getting pregnant. And, probably they will also have the, later menopause, as we have published in several papers, that there is about 2 to 3 years delayed menopause. And probably that estrogen is maybe protecting them, and they might have a better chance even to get a good quality embryo from that ovarian reserve if they are seeking for pregnancy at that time. But I think you're right, that there are probably good benefits of being able to utilize the nutritions and having that lush ovary. And I always say that to them. And this is a syndrome; it's not a disease. That's also very important to say to the women. It's a trait, and it's not a disease. So I think that's important what you are saying.
Okay. Thank you. I would like to thank all the speakers for very interesting talks, and all of you for joining us, and we can conclude this session. Thank you.